So, hi everyone, welcome to the 4D show. I am Dr. Prashant Arun, consultant physician and diabetologist at MV Hospital for Diabetes, Roypuram. And today's topic that we're going to be seeing is problems associated with diabetes care in India. Because when we say diabetes itself, people in India are scared. That is, they are scared whether their relatives will be taking them wrong, or then they're scared whether their medicines are going to be expensive and what's going to happen next. Everything just scares the people. So most of the time, they either are scared to come to the hospital, or next, they're even scared to take medicines because there are so many rumors going on. Maybe the neighbor says, or somebody is just talking to them. You take tablet, your kidney is going to go. You take insulin, your kidney is going to go. You are all these, this, that, this, every, so many rumors. So people are just scared these days. So, to give us a clear explanation about all these and help tell us about more problems associated with diabetes care in India, we have Dr. Abbamuni Baro with us. She is the Assistant Professor, Department of Endocrinology, GMCH, Guwahati. She's a consultant endocrinologist at Pratiksha Hospital, Guwahati. So, on to you.
Thank you. Thank you, Dr. Prashant. I take this opportunity to discuss today the problems associated with diabetes care in India. What are the problems that we commonly face when we tackle with management of diabetes in India? Are various, and to sum up, we have next slide. So, in India, there is a lack of general awareness about diabetes and its complication among the population. So many a times patients do not understand that even after having symptoms of weight loss, after having symptoms of polyuria, and also having any history of non-healing ulcers, so patients even now they do not go for blood glucose checkup. So as a result, there is a delay in the diagnosis of diabetes mellitus. So this happens in the rural as well as in many of the urban cities as well. So this lack of awareness is very less in Indian population. Also, the diagnosis and access to treatment for diabetes, especially in remote areas, is still lacking behind. Even in peripheries, we see that blood glucose is the last thing that the physician would check if a patient comes with some ailment. I think a patient, anybody who is above 45 years of age, blood glucose should be the first thing that has to be tested, even if the patient present to the hospital or the PHC or subcenter for other ailments as well. Also, there are economic disparities in the healthcare system. Again, there is scarcity of qualified healthcare personnel. Even today, we have a very lesser number of diabetes specialists who would know what is diabetes and how to manage diabetes in a proper way. A lot of quacks and non-medicos, they go for treatment of diabetes and actually when they treat diabetes without knowledge, a lot of chaos and problems do happen in the patient. Again, there are some financial constraints. In India, the patient has to take the burden of the financial the patient have to spend for their own medicines. So that is why there is a very big burden on the patient while managing his diabetes. Also, there are social barriers. As Dr. Prashant has already said that there are social barriers because many relatives or neighbors say that if you start diabetes medicines, you may have to take it for life. If you start medicines of diabetes, you may have kidney problem. So this lack of awareness and these social barriers are an important problems faced by our Indian diabetic patients. Next slide. So, what are the different factors that contribute to the cost of diabetes care? Number one is disposal medications. Number two is hospitalization. So many a times, because diabetes is diagnosed late in our country, so people do land up in hospital when they already have blood glucose of 400 or above, or they are in either diabetic ketoacidosis or there is complication. So again, they will require hospitalization, and it is a very big burden cost while managing diabetes care. Again, the doctor's visit. Per visit, again, these diabetic patients, they have to be on regular follow-up with their diabetes specialist. So at least minimum 3 monthly follow-up is required. And if in a well-controlled patient, 6 monthly follow-up is required. So again, the doctor's visit, that this also adds to the financial burden. Then again, yes, monitoring and laboratory test. Patients should monitor their blood glucose at least thrice, at least 4 times in a year or every 3 monthly, or and they have to do this test. So in that case, again, the patient has to pay for it, and again, this is again a burden on them. This anti-diabetic medications and other drugs like antihypertensive, anti-lipid drugs. So all these medications cost also contribute to the cost in diabetes care. Next slide. So, the barriers related to diabetes management can be again divided as patient related barriers as well as medical profession related barriers. So, patient related barriers can be again, as I have already mentioned, that it is lack of awareness, poor motivation, patient deny risk. Even we keep telling them, patients, that you are at risk of these complications, but they don't understand the risks. And also there is a stress, fear and confusion regarding the diagnosis as well as the management. They do not understand the benefits of immediate lowering of blood glucose. Also, there is lack of family and social support, lack of trust in doctors, and also lack of adherence to recommended guidelines. Many a times, patients do not know to whom, which doctors they have to visit. So they take treatment for from different people, and many a times patient mix up medicines. They take herbal medicines, they take ayurvedic medicines, they take allopathic medications all together, and they don't understand. Many a times people like don't go for allopathic medications and a proper guidance by a professional or a diabetes specialist, and they keep using home remedies for management of their diabetes even if their blood glucose are more than 400, and ultimately this makes them land up with complications. So this awareness is very very important, and which is specifically lacking in patients from India. There are again medical profession related barriers like medical training. Many a times doctors are focused onto acute care, especially in tertiary care hospitals, and they are the medical professionals or the doctor patient ratio is very very less. So there are very less number of doctors in the hospitals. As a result, they are more concerned or they are busy with management of acute care. So our patients of diabetes do not get adequate attention. Also, treatment of acute diseases, they become more rewarding for doctors. Even nurses, they find acute illness treatment more rewarding and better paying. Also, the cost of having a team for diabetes management is high. So, in many of the good hospitals, both peripheral as well as private hospitals and government hospitals, a diabetic team is not there. Also, there is lack of trained paramedics. Even many a times we find that the nurses, the paramedics, they are unaware of diabetes management, insulin techniques, and how to follow up patients. So these things are lacking in our setups, and especially in Indian setups. Next slide. So the therapeutic strategies. So we have so many medications coming. There are old medicines, there are new medicines. Some of the novel medications that has come, like DPP-4 inhibitors, SGLT2 inhibitors, and GLP-1 receptor analogs. So these are the novel medical therapies that has come and has been developed new. But then we also have other old medications like sulfonylureas, metformins, and also insulin, which is an injectable form for management of type 2 diabetes mellitus. So the therapeutic strategies, they differ, and it has to be tailored according to the patient's need, the patient's complications, underlying complications, as well as the patient's economic condition. So how much he will be able to pay for his diabetes management. Again, early initiation of therapy is very, very important because earlier the better. The early treatment would lead to a lesser complication and delayed complication. So, if a patient's blood glucose level is well controlled, even at an early stage, when uh, uh, he has not yet developed any complications, then we can increase his lifespan. He can be complication free, or he may not develop complications for a longer duration of period, and his quality of life would be much better. There is a new concept coming, and even the guidelines, the latest guidelines like American Diabetic Association guidelines, they also suggest that early initiation of combination therapy is a good approach to start even in a newly diagnosed diabetic patients, and this leads to achieving glycemic goals earlier than monotherapies, and also this will delay the deterioration of glycemic control. And also this combination therapies nowadays, they are proven, and it has been proved in literature that uh, early initiation of combination therapy can preserve beta cells of our pancreas, and the glycemic durability, the efficacy is much better than monotherapies. So if I am talking about combination therapies, combination could be metformin and SGLT2 inhibitors, metformin and DPP4 inhibitors, and etc. etc. So again, this combination therapy all depends on the underlying diabetes control or the baseline HbA1c. Also depends on the underlying complications. Like if the patient has chronic kidney disease, we will choose a particular type of combination. If the patient has or is at risk of atherosclerotic cardiovascular disease, he will need some type of other combinations. So all has to be based on the patient's requirement. Also, if a patient is at risk of hypoglycemia, if the patient is obese, all these things are actually deciding factors to decide upon what will be the combination therapy would like to start on the patient. For example, if a patient is obese and you want weight loss, if the patient has cardiovascular events or he is at increased risk of atherosclerotic cardiovascular disease, if the patient has proteinuria, he has developed chronic kidney disease, and there is protein in his urine, then metformin along with an SGLT2 inhibitor is a good combination to start in the early part of his treatment. Next slide. And other possible solutions, especially when we manage patients in the periphery, patient education and empowerment is very, very important. We have to tell patients what is diabetes, and we have to educate them about its management. And many a times we have to also empower them that you can we can empower the patient. If the patient is on suppose insulin, he's being prescribed a few units of insulin, then based on his glycemic control, we have to actually educate the patient how he can titrate the insulin dosage or titrate his medication doses. So even if at times we have seen during COVID period that patients were not being able to follow up with their doctors. So if we do patient education and empowerment, even during this type of crisis like COVID crisis, even in those times also, patient can be managed well with proper education and empowerment. Also, telemedicine is another option. Many nowadays, many people have smartphones, they have laptops, they have internets at home. So, educated patients can be given the option of telemedicine and can be regularly followed up for better management of diabetes mellitus. Thank you.
So that was a wonderful presentation. So we will just take up few questions. So as you said, that the cost of diabetes care, that's more, and people are actually more worried. Yes, that's definitely true, because even if a patient has to come to the OP, he number one loses his pay in his day job, so he has to take leave and he's going to come to the OP. So where he's going to actually lose his pay for that day, and he's going to spend in our OP. So he's going to spend his money and lose his money, and after which we are going to give him tests and medicine. So it's going to be very expensive. But then definitely, if a patient thinks on spending for the OP and detecting the disease, definitely the cost of treating the complication is going to be more. So definitely it is better that we always educate our patients. So as we said, like these telemedicine and other things, To improve the diabetes care, what would you feel is more important? Like, because these days more people are on social medias, they're on YouTube's, so maybe that will be useful, or directly educating the patient. What would be your perspective of educating the patient to improve the diabetes care in India?
Yeah, that is a very good question. So, to improve diabetes care in India, like people, because many of the people they are active in Facebook, they are active in Instagram, they are active in the social media. So we can actually post or discuss various problems faced in diabetes, and we can actually use these platforms to educate people about diabetes. So, just to inform you, like Endocrine Society of India, they have initiated similar awareness program in Facebook, so patient can go through, and then we are also a part of that. Again, the initiative that has been taken today by Sun Pharma regarding educating people, this type of platform is, I think, it is excellent for educating people and reach out to maximum people uh, like uh, uh, through this type of platforms. Again, like sometimes if possible, then the people or nurses and paramedic staffs and doctors in the periphery who are working in PHC, CHC, some centers, actually we can actually organize some awareness programs for them, maybe 1 day 2 day awareness programs in tertiary care hospitals, or doctors from the tertiary care center, specialist care, they can go to the periphery, and some programs initiative by government can be done. So in this way we can cover a lot of healthcare personals as well as the public as well.
Yes, because definitely nowadays, even if you want to look at anything, people first thing they do is go type in Google and see for the Google review. They want to go to a hospital, they check for the Google review. They want to look at a disease, they go to the Google review. So I think actually Google and the social media platforms are very good way for the next generation and all to educate the patients, because the patient tend to stay healthy because most of the time they are on social media. Next, I would like to ask you is, you were talking about these telemedicine. In your experience, are you satisfied, or how would you take telemedicine, and which patients can approach you on telemedicine? Because I'm very sure a patient having pedal edema, kidney disease, or a heart problem, it's very difficult to manage them through telemedicine because most of them take it wrong. These days most of the doctors get WhatsApp video call saying I have a heart chest pain, but I'm definitely sure a doctor cannot do anything with a chest pain in telemedicine. So which is the patient you would suggest for telemedicine, and which set of patients would you say, no, please don't try telemedicine, either come off to the physician straight away?
So, yeah, that is a very important issue. To my personal experience, what I like, because I'm practicing in Assam, Guwahati, so many are patients like who are educated, and then they can use the social media well, and they are well versed with how to connect to a doctor. Like many a times we share the link, but they are unable to join. So, many a times the educated people who have a good internet backup, and then they can join us through internet, and patients who have just hyperglycemia, and who has been already seen once physically, so on follow up maybe I have to check their HbA1c, or I have to check their fasting and postprandial blood glucose levels and adjust their doses. Those cases without complications can be tackled, or can be actually uh, like uh, uh, consulted through telemedicine. But again, if patient have complications like chronic kidney disease, patient have cardiovascular disease, patient have any complications, when I have seen the patient physically, then it is always better to tell the patient to come up and show physically, because many a times it is very difficult through telemedicine to assess your clinical signs and symptoms, and many a times patient may not be aware that this type of symptoms are important, so only a consultant physician will be able to pick up those signs. So that is very important. And again, I had tried many patients staying in the rural areas, if they can come up like if I can consult them through telemedicine. I had tried during the COVID period, but it creates more of a chaos, what I found it. So eventually when COVID restrictions were like taken up, then I had almost told all the patients to come up and follow up physically in my OPD.
Yes, very good, well
So with
said. Because even I am a
complications, it is
person.
better. With complications, it is better. Don't rely on patients' complaints and
Yes,
then call them physically. And if not possible to come to your place, at least nearby area wherever registered doctor or doctors are available to go and show there. And again, yes, sometimes what happens, we have started patients on insulin for their glycemic control. Again, after 3 days, it is difficult for the patient to come and visit me. Then I can, yes, tell them that please share your SMBG or blood glucose level in WhatsApp. I can actually titrate the insulin dose accordingly. But again, they have to come to follow up at least after a month. So I think visiting a doctor should be made mandatory. Otherwise, following up in telemedicine, this can lead to a lot of fallacies, and we can miss important clues.
correct, correct. Because very well said. Because once we start insulin, yes, maybe post 1 week or post 2 weeks, definitely maintaining their SMBG chart, we can see them through WhatsApp video consultation or telemedicine. But definitely on a long run, maybe 3 months or 6 months once, it is always better that the patient comes to us for us to examine, because no consultation is over without touching the patient, because one thing, the patient is not going to be satisfied. Number two, we don't know what is going on with the patient inside the body. But taking into consideration that we were talking about SMBG, that is a self monitoring of blood glucose, which sugars would you check for your patients? How would you tell them to maintain the SMBG chart? Because not everybody is aware of this self monitoring of blood glucose. They just think coming to the doctor, checking the fasting and postprandial is enough. Because that's what I ask my patients. No, diabetes is not present only during fasting and postprandial. Lunchtime, dinner time, evening time, midnight, sleep. Full time, the blood sugars need to be normal for the HbA1c to come down. So, which sugars would you tell your patients to check, and what kind of pattern would you maintain on an SMBG chart to a patient?
Yeah, again, it all depends on the patient's baseline blood glucose status and HbA1c. Suppose a patient with newly diagnosed diabetes mellitus with somewhat HbA1c of maybe 7.58, not a very bad glycemic status, and I have started the patient on oral hypoglycemic agent. Patient does not have any complication. In those patients, I will tell the patient maybe after a month or two, you check your fasting and postprandial blood glucose levels, and at the interval of 3 months you can check your HbA1c and follow up. So this can be prescribed to the patients. And postprandial, it is very important that when I prescribe oral hypoglycemic agents, many at times patient would stop their oral hypoglycemic agent or the medicine and then do their postprandial. So this has to be educated to the patient that you have to be on medications, and on medications you have to check your blood glucose. Like for fasting, the previous day you have to take your medicines, and also for postprandial you have to take the medicines before taking the breakfast. Then you take your breakfast, and after that only check the BP. So taking tablet is important on the day of testing. Secondly, if the patient comes to me with a very deranged blood glucose, maybe the patient has blood glucose maybe more than 400, maybe patient HbA1c is more than 10%. So in such patients, if I start the patient on insulin and if he has complications, then I would suggest the patient to do a SMBG charting. I'll tell the patient, if I've started the patient on basal bolus, that is 4 times insulin, then I'll definitely tell the patient that check your fasting blood glucose. And because our patients, they take a lot of carbohydrates in their diet, so in our setup, we are mainly seeing the postprandial blood glucose, that is 2 hours after taking their breakfast, lunch, and dinner. So 5 times blood glucose checking would have it is better to actually titrate the insulin level till we get a stable and controlled blood glucose level, especially during the first 1-2 weeks. And then eventually we can reduce the number of pricks and reduce the number of blood glucose checking in such patients eventually when his blood glucose is controlled. So again, it depends. If the patient is on insulin, he will require more frequent blood glucose. In addition to this, I would also say that nowadays we have continuous glucose monitoring system. So in patients with type 1 diabetes mellitus, patients who are on insulin, who are at risk of hypoglycemia, patients who are CKD, chronic kidney disease, or heart patients. So in such patients, or patients who have a very fluctuating blood glucose, so we have continuous glucose monitoring systems where we put a sensor in their fix a sensor in their body, and we can get real time checking of their blood glucose. So anytime we can check their blood, we can, whenever we want, then we can actually see the blood glucose. So that gives a continuous reading of the patient's blood glucose status. So that is also an option. So it all depends on the patient to patient, yeah. And as I have suggested, patients on insulin will require at least a 5 point or 5 times blood glucose monitoring. And our some of the American guidelines, they suggest that pre meal blood glucose to be monitored, and they have given guidelines or some cutoffs for pre meal. So that can also be used, but in our setup, more often we actually checking the postprandial status.
Sure. In your opinion, why is India moving towards the diabetes capital, and what can be done to stop India from becoming the diabetes capital? And because lately we've got these CGMS, the continuous glucose monitoring system, we've got drugs like the SGLT2 inhibitors, the GLP-1 analogs, we've got so many wonderful drugs that are coming in, helping in preventing the complications of diabetes and all that. Then what more can we do to, prevent India from becoming the capital of diabetes?
We as Indians, we are actually more insulin resistant by birth. We are more insulin resistant as compared to Caucasians or the Western world. So we, even at a lower BMI, even if we are lean, then also we may be at higher risk of diabetes. There are a lot of reasons. Genetically we are more like insulin resistant. Again, the Indian people, they have like more of DPP 4 enzymes. And also as a race, also it's also a race, racial factor also, that we are at increased risk of diabetes, metabolic syndrome. And because India is developing very rapidly, and uh, uh, there is modernization and our lifestyles are changing, and then we actually our lifestyle are becoming more sedentary and more stressful, because our forefathers, what were they were actually farmers, and then they were very hardworking people, and there were a lot of physical activity in their day-to-day life. But with modernization, we actually shifting towards a more sedentary lifestyle, and our genetic is not made for that. That is the reason I feel that Indian people are at more risk of diabetes and metabolic syndrome. And to reduce the incidence and prevalence of diabetes in India, number one, awareness is very important, and that should start right from children. So, patient education, I think the target should be school children as well. So, in school awareness program should be conducted, where children should be taught about obesity, the problems with obesity. So, we have to tell that obesity is not good in India. Many people think that okay, mota bacha hai to healthy bacha hai. So I think that concept has to go. So mota bacha is not a healthy bacha. Mota bacha looks cute, but then in long run this is not good for the health of the child. Secondly, patient or children or general public has to be aware what is healthy and unhealthy for them. So the food choices has to be told to the patients as a preventive measures. So what are healthy food nowadays in India? We have KFC, we have all the multinational fast food companies are there, and we have so many branches in, I think, every locality there is a branch. So those four fast food consumption is becoming very very high nowadays. So again, that has to be taught right from the beginning, that this has to be stopped. And then the healthy choices of food is important, physical activity is important. Then like uh, if the patient has or any person have a family history of diabetes, he should be aware that okay, he's also at risk of developing diabetes. So early screening is very very important. So ADA guidelines or American Diabetic guidelines, they say that anybody who is more than 45 years, you have to check your blood glucose once. But like I would suggest that for Indians, we choose even an early age to monitor or screen for blood glucose levels for diabetes in patients, because blood glucose may start rising even before you become symptomatic. So we should not wait for symptoms to arise, and we should choose early age for screening for diabetes in Indian population.
Sure. So we'll just move on to the last question. That is, we've got these SGLT2 inhibitors now. So how is this SGLT2 inhibitors changed the diabetes care? What are the changes that it has made in the diabetes care, and why is everybody suddenly talking about the SGLT2 inhibitors? Now we have got, first it came with the dual drug combination. Now we have the triple drug combination. So, what are your views on these single SGLT2s, double drug, triple drug, and where would you use it? Do you use it? Do you like using your SGLT2 inhibitors separately, or do you use it as a triple drug or double drug combination?
So SGLT2 inhibitors, they are an important inventions or discoveries, I would say, in the management of diabetes mellitus. And then this SGLT2 inhibitors, uh, it this like actually has been incorporated in all the guidelines to be given to our patients, even in the even in the early part of the diabetes, even in newly diagnosed diabetes mellitus. If the patient has chronic kidney disease, if the patient has proteinuria in the urine, or if the patient has risk of atherosclerotic cardiovascular disease, or he have some cardiac risk, so SGLT2 inhibitors has to be started even in the early part of the disease or as a combination with metformin. So previous guidelines were like you start metformin and lifestyle modification, and start with a monotherapy, and then gradually step up to dual therapy, then triple therapy, and then addition of insulin and so on. But now the concept has changed. The latest guidelines and the latest concept is that we have to give the benefit of dual therapy or combination therapy to patients of patients of diabetes, because diabetes pathophysiology, there are multiple factors. Like in previously only a few factors were attributed for pathogenesis of diabetes. Now it is the ominous octet. Like there are almost eight abnormalities or problems or pathogenesis that leads to diabetes mellitus. And until and unless we tackle this pathogenesis differently, we will not be able to give a proper treatment to our patients. So to tackle this different abnormalities that happen in a person's body when he develops diabetes, so a early combination therapy would give a better results in terms of glycemic control, in terms of durability of the treatment and efficacy, and in terms of complications. So because SGLT2 inhibitors, they are known to reduce the proteinuria in patients with diabetes mellitus. They are known to reduce the risk of cardiovascular disease in patients with diabetes mellitus. They are known to reduce the weight of the patient, because even weight of the even patients who are overweight, they are more prone to develop type 2 diabetes mellitus. So we need a drug which will reduce the weight of the patient, and we want to avoid drugs or diabetic drugs which will actually lead to weight gain. So SGLT2 inhibitors, I would say that it is a boon to diabetes management. And then starting this SGLT2 inhibitors in combination with metformin when the patient is newly diagnosed with type 2 mellitus, and if he has obesity, number two, if he has proteinuria in the urine, if he has cardiovascular risk, then these combinations would be much beneficial to him as compared to starting a monotherapy.
So, very well said. I think we've actually helped a lot of public by educating them today, and this is what is needed actually, more and more of diabetes education, where the public can learn about the newer molecules. It's not only the doctors, even the public need to be aware that there is a molecule that can actually improve their kidney function, reduce the proteinuria, help them lose weight. Because people just think, because always what they hear from their neighbors and the social things are that, take tablets, then you'll have to continue your tablet lifelong. Your tablets could produce kidney problem. So I think people should start hearing more from CMEs and sessions like these, that tablets are really useful and these tablets can help avoid complications due to diabetes. So we are looking forward to do more and more sessions with you, Doctor. So as of now, I think we'll have to wind up this session. Thank you so much for taking part and giving us the opportunity to have you in this session. Thank you so much.